My name is Tom Gibbons. I'm the Madison County State's Attorney, and along with a whole lot of other people that we consider stakeholders in this public problem of heroin and opiate addiction, I'm here to learn from presenters. The whole point of the task force is for us to reach outside of law enforcement. We spent about 3 years with most of our efforts dedicated to law enforcement. And we know that that's not enough, that's just one piece of the puzzle. So the task force is designed to try and get more information, to reach wider, to get ideas from people who see this from other points of view and who have other information to offer. With that in mind, today we're going to hear from representatives from 2 drug treatment providers. This is an area that I don't have a lot of personal information about, and I'm really looking forward to this because I think that I have a lot to learn when it comes to understanding the treatment aspects of opiate addiction. I think many of us in this room are the same way. We have a lot to learn, and the whole point of the task force is to learn, to gather as much information as we can, and then try and figure out where there are things that we can do better. Things not just with law enforcement, but focused on dealing with what we know is a whole group of active people who are addicted to opiates and people whose lives, and not just the people who are addicted, their families. What things can we be doing better to help deal with this problem? I just want to remind everybody, if you are not on the email distribution list, you can send in an email to madco.taskforce@co.madison.il.us. I'll repeat that. That's the email address, and we're sending out notices and information through that so that anybody who's interested can get notice about these things. If you have an email and if you want to say something to the task force, you can write an email. We've got some very, very interesting submissions through the email from people, families, community members, recovering addicts, just interesting things sent. And we're trying to share as much of that information with everybody, make that part of the body of information that we're collecting through the task force. And so we're willing to accept whatever information people are willing to give. This is a learning process. And I'll be the first to tell you, there's a whole lot I don't know and that I want to learn. The only way we're going to deal with this problem and have any success dealing with it is that we all talk honestly and openly, and we open our minds and our hearts and hear about this so that we can deal with this really real public health issue. Again, the email address is Madco Task Force, MADCOTASKFORCE @co.madison.il.us. If you're not connected yet, get connected, please. If you have something to share or something to add to this, please do. This is not a closed process, this is an open process. Today we're going to hear from 2 of our local treatment providers to give us some information about what they do. I'm very interested to hear what they do. Maybe they can tell us what we're doing well, where we're falling down, if there are pitfalls, if there are barriers to access, whatever they've got to share with us. I'm really looking forward to it. After each speaker, I think there are some note cards. You can write down a question. Just, if you have a question for the speaker, write it down. If you have a statement you'd like to make, you can write it down and hand it in, but I'm probably not going to read it. What we're trying to do is, while we have these people here and we have their brains to pick, let's ask questions that apply to what they have to say today. If you have a question or a statement to the task force itself, you can submit it. Just know it's not going to probably be read openly, but you can email it if you want to take more time and write that. But without further ado, I'm going to introduce Julie Brewer from Chestnut Health Systems, and I'm really looking forward to talking. If you want to come up here, if you have a mic, you may have a working mic there too.
We're going to start with Wellspring. Actually, we're
we are? Okay. I'm just following. Okay, Jessica Park is from Wellspring Resources, and so let's start with Jessica.
Hi everybody, my name is Jessica Parks. I'm a substance abuse counselor at Wellspring Resources over in Albany. I am part of the medication medication-assisted recovery services program there. Just a little bit about me. I've been in the field of substance abuse for 10 years now. Most of that time has been over at Wellspring working in the substance abuse services program. Our program is, like I said, the medication-assisted recovery services program. We have been serving individuals who are physically dependent on opiates since 1976. So that's just a little background on our program and how long we've been providing services in Madison County. The agenda that I'd like to get through today, we're going to talk a little bit about some of the frequently asked questions that are associated with opiate dependence. You may be wondering why you should be concerned, why don't people just quit? More importantly, what are my treatment options? And I'm going to talk a little bit about the program that we have over at Wellspring. And then we're going to talk about different aspects of our program, about opiate dependence in pregnancy, putting the pieces back together specifically in terms of therapy for individual and group counseling. And then you're also going to hear from my coworker Kelly Medlin, and she's going to present a story of one of the clients that we've had come through services with us that we consider to be a success. So I'm going to start and go over why should we even be concerned with this issue in our community. Opiate dependence is not a new problem in the U.S. It's growing at an alarming rate, particularly among our young adult population. The young adult population, meaning 18 to 25 years of age, is booming right now in terms of an increase in opiate use and abuse and dependence. There have been several heroin overdoses and deaths in the news lately, many just even within the past week that we've heard about. So it's in our community. It is a problem that is in Madison County, Illinois right now. Oftentimes, opiate dependence or the road to opiate dependence starts with prescription painkillers. So research has suggested that this actually opens the door to heroin use. And in an article by the National Institute on Drug Abuse, young people who were injected with heroin were surveyed, and nearly half that were surveyed reported abusing prescription opiates before starting heroin. So oftentimes that's how the whole problem even begins. Anyone can become physically dependent on opiates. And I just want you to think for a second if you yourself have ever maybe had surgery, gone to the dentist, had a tooth pulled, had opiates prescribed to you in terms of being a painkiller. That's really common. If you know anybody who has ever been through a surgery or had an injury of any sort, how many people have been in that position to where you've had surgery or been prescribed painkillers from a doctor? Okay, it's not uncommon. Anyone who takes those medications, I don't think that a lot of people realize that a physiological dependence to opiates can occur in as little as 2 weeks' time. That's pretty significant when you think about it. And like I said, that's often how the road to heroin use in particular even begins. I also want to make sure that, because this is such a big problem in our community today, people that have issues with opiate dependence aren't those people any longer. We are now talking about our family members. We are now talking about our best friends, our cousins, our uncles, our children. This is hitting close to home. This is not, some aspect of society that we no longer talk about. It's in our face every day, which is another reason that, it's so important to address in our community today. Our medical director at Wellspring, her name is Dr. Donna Boone. She's been doing what she's been doing for a long time. She's helped many, many people in the community. She kind of gave us a rundown, a little tidbit about how opiates work in the brain. So she explained that everybody has the same opiate receptors in the brain. And what happens when you use an opiate is that the opiates fill those receptors in your brain, which produces this feeling of euphoria. And that's the feeling that most people associate with getting high. Getting high feels good. It produces that feeling when those receptors in the brain are filled. It's kind of a domino effect. The more opiates you use, the more receptors your brain actually produces, okay? This results in what we call tolerance. When you have a tolerance to a drug, that means that you have to take more and more of that substance in order to get the same desired effect. So you have to use more and more opiates to keep getting that euphoric feeling that's associated with getting high. So over time, what happens is that you're creating all of these opiate receptors in your brain, and then if you can't get enough of the substance that you're using, or you stop using altogether, the opiate receptors in your brain aren't filled, and that's when the symptoms of withdrawal start to occur. There are several different symptoms of opiate withdrawal. If anyone in here has ever come in contact with a person in opiate withdrawal, it's not a pretty picture. Oftentimes they have many physical issues going on: nausea, diarrhea, sweating, weakness. From what I've been told, in terms of what opiate withdrawal feels like, it's kind of like having the flu times 1,000. You're not able to function, you're not able to get out of bed, you are sick to your stomach, you cannot move. It's a horrible, horrible thing to go through. If opiate users do not find opiates to use, withdrawal symptoms can start in as few as a few hours. So it becomes all-consuming. It's this terrible form of chemical slavery that occurs, because then you've got a person who is constantly on the run looking for their next fix, for their next way to ward off those withdrawal symptoms. Because over time, what happens is now you have a person that has built up their tolerance so much because of the substances that they're using, that it's no longer about getting high, it's now about not being sick. It's now about, what do I need to do to get a hold of this substance so that I can even function at all? Because if I don't have any of my symptoms in my system, I'm not going to be able to function. So it's not that long-term opiate users are even looking to get high anymore. It's that they don't want to go through the symptoms of withdrawal. I want to talk a little bit about the routes of administration, because I think that that plays a key role in terms of what people go through, and it also plays into the road to dependence and specifically heroin use. Mostly, like I stated before, lots of times people end up dependent on opiates. They usually started out with some sort of pain pill, okay? So everybody has taken Tylenol if you've had a headache, let's say. So when you take Tylenol, okay, say 20, 30 minutes later, your headache starts to go away and those symptoms of your headache start to subside. That's because in oral route of administration, when you take a pill and you swallow it, that's the slowest route of administration in terms of that substance getting into your bloodstream and getting into your body, okay? So that takes 20 to 30 minutes. After that, what happens is you have a user who is abusing pills, and they're taking several pills. They're starting to take more than what was prescribed to them. And then they start getting into the drug-using behaviors. At this point, what they do is they start to crush the pills up and snort them. Using a substance intranasally or snorting it is the next step up in terms of routes of administration. It's important that you understand that the route of administration makes a big difference in how addictive that substance is. The faster it gets into your system, the more your brain is going to respond to that, and the more addicted you're going to become to that substance. So people figure out that they can get that feeling, they can get that the substance into their system faster, so they're looking for the fastest way to get into their system. After snorting or using it intranasally, people often go to smoking, and then eventually it ends up with your IV use, which is what a lot of people associate with heroin use. If you're using a substance and you're using it IV, the time it takes to get into your system, it's practically instantaneous. You're going to feel that substance in your system right away, and that's when you're talking it becomes highly, highly, highly addictive. The focus of our presentation today is really to present a picture of hope and tell you more about what the treatment options are in terms of heroin use and opiate use. So there are a few different treatment options. The first one that I want to talk about is detoxification. Usually the detoxification process is a 3-day process. Somebody is admitted into a medical facility and they're being medically monitored while they're there. In my experience, what I've heard from people that have gone through a detoxification process is that 3 days is not nearly long enough for them to become stable. So what ends up happening is if you go to a detoxification program, you're often discharged in 3 days. And the problem with that is you have the height of your withdrawal symptoms occurring at the time that you're discharged from that facility. So what often ends up happening is that you see a huge amount of relapse because the problem hasn't really been addressed. The second option, which we provide at Wellspring, is medication-assisted recovery services. At our facility, we're talking specifically about methadone maintenance treatment. Methadone helps to repair and rebuild lives while helping the individual to become physiologically stable. There are much higher rates of success that are associated with medically assisted treatment than through going through a detoxification program alone. You may be wondering, what is methadone and how does it work and why is it such a good treatment option in terms of opiate dependence? Methadone is a long-acting synthetic narcotic. It works a little differently in the brain than your typical opiate does. What methadone does is instead of going into the brain and filling your opiate receptors, what they do is they cover the receptor up. So that results not in the euphoric feeling that's produced by the substance being put into the receptor. It actually covers the receptor so that you don't feel the symptoms of withdrawal. Methadone does not get someone high. Methadone simply prevents someone from going into withdrawal and experiencing those symptoms of withdrawal. How does methadone work? As I mentioned, there's no euphoria that's associated with methadone. The people that are coming into our agency and dosing on methadone do not experience any symptoms of withdrawal if they're being maintained on a proper dose of methadone, which is medically monitored by our program director. One dose of methadone, it is extraordinarily long-lasting. One dose of methadone is enough to keep someone stable for 24 to 36 hours. If you're using heroin, okay, especially if you're using IV, you have to use about 4 hours after the last time you used or those symptoms of withdrawal start to set in. So part of the benefit of methadone is that because it's so long acting, it allows people to start to live a normal life. They're able to do things like go out and hold a job. They're able to focus on their families. They are able to reduce all of the risks that are associated with active use. They're not out committing crimes so that they can get the money associated with their next dose. It's taken once a day. When people come into our facility, it's given in liquid form. It's given in liquid form because a liquid form of methadone is harder to divert. It's harder to take out of the facility and sell. It's not in a pill form. It's not in a wafer form. What happens is that our clients come up to the dosing window with our nurses, and they dose for that day in front of our nurse so that the nurses can monitor them for symptoms of withdrawal. Our nurses can monitor to make sure that they're taking the medication the way that they're supposed to take it. So it's very highly regulated. All of the clients that come into our facility are seen every time that they come in by a medical professional. In addition to the medical professionals, you have to have a specific DEA license in order to even prescribe methadone. So that's what our doctor has. She has a license that was given to her by the DEA so that she has a specialty and is able to prescribe methadone. So I want you to understand how highly regulated our program is and how highly regulated methadone is as a substance. Our program is also regularly audited and regulated by the Department of Alcohol and Substance Abuse in the state of Illinois. Everything is accounted for, everything is regulated in our program. So that's another safety precaution that we have and that we use. The process for getting services through Wellspring, we have an open access model in terms of coming in for services, and that means that anybody can come into our facility between the hours of 9 a.m. and 2 p.m. Monday through Friday, and we have clinicians that are available that will take people on a walk-in basis and see them for a comprehensive assessment. Once that comprehensive assessment is done, they then see another clinician to set up a treatment plan, and they begin therapy services. They begin individual counseling. They begin group counseling. They also receive tons of other services in addition to that. We provide wonderful case management for our consumers. They have an evaluation that's done by the medical director of our program. She sees each and every one of our consumers before they begin dosing on methadone. The methadone treatment itself may not begin for several weeks, and here's why. At Wellspring, we're very focused on the therapy, both group and individual, that goes with the methadone, because we view methadone as simply a tool to aid someone in recovery. Recovery comes from the actual counseling and being in groups and working on the specific issues that take place, and that's associated with the active addiction and why they began using. Currently, our methadone clinic serves 230 people, and that is only growing. We are in a position now where we are having trouble keeping up with the demand for our services because this has become such an overwhelming issue in our area. We have people come in all the time that are looking for services, and it's been a struggle to try and keep up with that demand. There's a fee associated with the program. It's $90 to $120 a week, depending on your income. Everybody sees a registration specialist when they come in to help determine that cost. And then, like I said, there are many different services that the individuals coming into our agency are able to receive. The individual and group counseling is absolutely crucial. They also receive lots of case management services. We come from a philosophy of risk reduction. So our philosophy is that we are kind of meeting the client where they are. They come into our facility. We are able to get them physiologically stable with the methadone, and then they have the opportunity to become stable in all of their other areas of life. They're no longer out hustling, trying to make crimes. They're not engaging in risky sexual behaviors. They're not at risk for either receiving or transmitting communicable diseases because they're no longer using needles. So we are reducing all of those risks, not only for that person presenting for treatment, but also for the community. Crime is going to go down. All of those things that I just talked about, that helps to make our community stronger because we are now addressing that issue in treatment, and we're helping to get that person stable across all their different areas of life. As I mentioned, recovery is really the ultimate goal, and we help to accomplish that through individual and group therapy. I want to make sure that everyone here understands that our program is a counseling program that happens to have a specialty in substance abuse treatment. Okay? We are very, very focused on the counseling because we know that that's where the real change takes place. If we can get people physiologically stable, that gives them the opportunity to address the issues as to why they even started using drugs in the first place. As I mentioned before, methadone is just a tool to help aid in that process. So in terms of putting the pieces back together, that's what happens in counseling. That is what happens in individual and group therapy. So we get into all of the different things that happen in active addiction. We talk about, the fact that they may have stolen from or lied to or alienated themselves from families and loved ones. We talk about, maybe they lost their job. Maybe they went through their entire life savings. Maybe they've been arrested and had all sorts of legal issues. Many of the consumers that come into our agency have chronic health issues, ranging anywhere from HIV to a plethora of different things. Of course, their self-esteem is way down there. We work really hard with all of the people that present for services to build them back up and to have them have a sense of self-worth again. Because without that, they're not going to get very far, whether they're clean or not. We focus on treating the whole person rather than just handing out medication, and that's really crucial to the success of the people that we serve. The other thing that we do is that people really get the opportunity to become parents. Once they come into our program, we see so many people that come in with young children, and they may be, you know, putting their kids in dangerous situations. They have no idea how to be a parent because their focus is not on parenting. Their focus is not on their child. Their focus is, how am I going to keep from being sick today? So when they come into our program, it's risk reduction for that person, but as I mentioned before, it's also risk reduction in terms of kids, it's families, the community, everyone. You know, when people come in, they get the opportunity to do that and be the parent that we know they can be for their child. How long will methadone treatment take? That is one of the most frequently asked questions that we get. There's not really one answer that I can provide to that. We believe that everybody's recovery is going to look different because no two people are the same. No two people walk through our door and have the same issues. The goal for our program is that everyone in the program eventually goes through a medically supervised withdrawal process, and we can work with the medical director and with our nurses to make sure that they do that in a healthy way. But that's not always the case for everyone. Some people need to continue on the same amount of medication that they have been on in order to remain stable. The medically supervised withdrawal process really is in terms of achieving stability. They are not in withdrawal while they're going through that medically supervised withdrawal. We are able to keep them medically stable. They are still continuing to work with our clinicians and attend groups so that they remain emotionally stable. We go through and we address all of their different life stressors to make sure that they're stable in all of those areas. Have your legal issues been taken care of? Do you have DCFS involvement? You know, what's going at home? Is your recovery environment supportive of you being clean and sober? You know, are you attending support meetings? All of those things. What's your risk of relapse? Do you have a relapse prevention plan in place? We make sure that all of those pieces are put together before we go through that medically supervised withdrawal process with anyone. Okay. I want to talk a little bit about opiate dependency and pregnancy. We have a lot of people that present at our agency when they are pregnant, and as you can imagine, that is concerning because now you're really talking about two lives instead of one. You're talking about the life of mom, and you're also talking about the life of the fetus. What I want you to realize in that regard is that whatever mom is feeling, if mom is experiencing physiological symptoms of withdrawal, so is the fetus. And that is incredibly, incredibly risky. That can ultimately lead to fetal demise, fetal distress. It can lead to preterm labor. So part of our goal with people that present when they're pregnant, our goal for them is to make sure that they've got adequate prenatal care. We make referrals over to high-risk clinics for pregnancy to make sure that they're getting the care that they need and they can have the healthiest pregnancy possible. Methadone helps to keep mom and baby stable while mom is carrying. It also gives mom the opportunity to learn those important parenting skills like I mentioned before. We have groups that are even specific to parenting groups, increasing those skills. If mom has the opportunity to work on those things before she gives birth, that not only increases the likelihood that, you know, she's going to have those skills develop, but it also increases the likelihood that she's going to stay clean after she gives birth to that baby. Services don't end once somebody gives birth. That's just where the process began for that person. So our goal is really to make sure that the women and the babies can both stay healthy during the entire process of pregnancy. Okay, what can you do? So some of the things that you guys can focus on in terms of addressing this issue in our community is that we can work together to help minimize opiate use. I noticed on the door on the way in that there's the prescription drug take-back program. It's really important that you keep track of your prescription medications, keep them locked up or dispose of them in a safe way, because the majority of our young adults, I talked about how they often start the process of addiction through the use of pain pills, and they're getting those out on the street. They're getting them from mom and dad's medicine cabinet. So just being aware of the fact that you may have those prescription medications around and where they're going is important. Talk to your kids, educate them, make sure that they know what's going on in the community, make them a part of being aware of what's going on in the community, and helping to be a part of the problem-solving process there. Part of what we're trying to do is to break this stigma that's associated with addiction in general, but also specifically in terms of methadone, and also to let people know that there's hope. I think that's probably the most important thing that we want to have people at this meeting today leave with. We want you guys to know that there's help out there if people want it. We have a good program. We're able to instill that hope into the people that come into our agency and they don't know what else to do. They're in a desperate state and we're able to give that back to them, and that's why we do what we do. I am actually going to let Kelly Medlin come up, and she's going to read a story about one of the consumers that have been through our program, because we think that she's been very successful, so I wanted her to be able to go ahead and share that with you all. So I'll let Kelly talk about that.
Hi, I met with one of our consumers, Rachel, to talk about her experience in the methadone program, and so I just wanted to read to you what she told me. I was a young woman with 2 children in a very bad marriage and very unhappy. I look back and realize now that I was depressed, having headaches, lots of stress, and probably drinking more than I should. When I went to my doctor and told him about my headaches, he prescribed Vicodin. I took them as prescribed, and within 3 months called my doctor and explained that when I didn't take the Vicodin, I felt sick, nauseous, shaky, and thought something was wrong. He told me that I must be abusing the Vicodin and hung up on me. A few days later, I received a letter from him saying that he would no longer be my doctor. At that point, I was already physically and emotionally dependent on the medication, but it took more and more to get the same feeling from them. Eventually, I was spending all day, most days, going from doctor to doctor, pharmacy to pharmacy, and dragging my kids with me. When you're addicted, all you can think about is where you will get that next dose. It's the only thing you can think of. It's a constant thought. I could have a bottle of pills in front of me, but would be worried about where the next one would come from. It is really hard for people to understand the utter desperation. At that time, I did things I never could imagine I would do just to get the next dose. I lied to my parents and my family members and even stole from them. I once stole a bottle of painkillers from my mother, who was recovering from surgery. She needed the medication more than I did, but at that time, I just couldn't see past my addiction. Needless to say, my relationship suffered. My family have told me that they were afraid to come to my house at that time because they were afraid they would find me dead. I was depressed, filled with guilt, and a sense of hopelessness. By the time I came to Wellspring, I was taking approximately 50 to 55 Vicodin, Percocet, or whatever painkiller I could get that day. I tried to wean myself off. I don't think if you've never been through opiate withdrawal, you can have a true understanding of how difficult it is. When that didn't work, I tried to go to rehab. But the doctor sent me home because I was only on pills. I really felt like I had nowhere to run. Finally, a new doctor from whom I was trying to get yet another opiate prescription recognized the abuse and called me on it. I broke down and told him I wanted to get off of them. He suggested methadone treatment. I had never heard of it before, and no one had ever suggested it to me, and through some research I found Wellspring. When I started at Wellspring's MARS program, the Medication Assisted Recovery Services, I no longer had to worry about getting my next dosage, but I recognized that my addictive personality wouldn't just go away. I had to learn how to function and cope with stress without turning to drugs or alcohol. I participated in individual and group therapy. I learned new ways of thinking. With the help of some great counselors and nurses, I learned to like myself again and rebuild the relationships I had damaged. They gave me the courage to change my life for the better. With this program, I have been given the opportunity to have a normal life again, and most importantly, to take care of my children and really be there for them. I have been in treatment for 10 years now. In that time, I earned my GED, went to college, and even earned a bachelor's degree in teaching. I've had struggles in that time, but in the MARS program, I was able to get the support I needed and can proudly say I have not gone back to drugs. I am slowly being weaned off of methadone and feel that I now have the skills and support system to graduate from the program. I live a very normal, healthy life with my children. I have a great, trusting relationship with my parents and my family members. I'm not able to share my experiences with my students, but if hearing my story will help prevent one person from using, push someone to talk to their doctor about their concerns, or convince someone that there is hope, then I think my story should be told. I truly believe that if I had continued to use, it was only a matter of time before I overdosed. If it wasn't for this program and the wonderful, kind providers, I would be dead right now, and my children would be without a mother. I'm so thankful for each day that I can wake up and be the person that I was meant to be. Jessica, do you want to finish up?
Thank you, Kelly, for sharing that story. One of the reasons that we wanted to tell that story today is because Rachel is a wonderful example of how life-saving medication-assisted treatment can be. The unfortunate reality is that in our community today, there are so many people that are struggling with addiction that there are a lot of people that don't get that opportunity or that die before we can be able to provide that help. I realize the audience that I'm talking to, so I just wondered how many people we have in the room that have been personally affected by somebody you've lost through an overdose. So a good number of you. Our purpose today is really to let you know that there's hope out there and that there are options for treatment out there. And if we're able to help people and save lives, then that's our whole purpose in being here today. If there are any questions about our program or anything, I would be happy to try and answer those.
Jessica, let's say I'm 40 years old, I'm addicted to heroin, I want to get off of it, but I don't have, really the only note I made here is the $90 to $120 a week. I really want to get off of it. It sounds like your program is good, but I don't have any money. Can I still come to your place?
You can absolutely still receive services through our agency. The process is actually the same. You'd still go in for your comprehensive assessment through our open access model, and you would talk to our clinicians and have your assessment done. And then you would work with somebody specifically in the substance abuse program to set up your treatment plan and define what your goals are for treatment. And then you would begin individual and group counseling. The only thing that would be missing out of that equation is the actual methadone itself.
So the person that's got $120 a week gets better treatment than I get?
I wouldn't say it's better. The only part that you're missing again is the actual medication. Methadone doesn't make treatment better. It's just a tool to help you in recovery. The real work of recovery comes through individual and group counseling, and we'll offer that to anybody regardless of ability to pay.
My chances for success increased because I don't have the 120?
I think it depends on the person that you are and the types of situations and clinical issues that you're presenting with.
So it would help to have the money.
It would help to have the money if you want methadone, sure. But like I said, that's not what our program is focused on. Our program is focused on helping the whole person, and you do that through individual and group counseling.
I have a question.
Mhm.
Would you say that there are, or what percentage or what size of population of people would you say would not be able to, because of financial reasons, not be able to access that part of the treatment? What is sort of, and what I'm getting is, what is the scale of the need that's not being addressed? If you had, in an ideal world, the ability to provide that to everybody, how many or to what degree do you think that that's not available? Because we're looking for solutions. We're looking to say, okay, where are we missing some of the pieces, and how do we do something about it?
One of the things that I want to stress is that there is help out there for whoever wants it. Anyone can come to our facility, and anyone can receive services through our facility because of our open access model, and because of the fact that depending on your income, you know, you may receive services absolutely free of charge depending on what your circumstances are. That will be through individual and group counseling, so the help is there. If you specifically want methadone, in my experience, what I have found to be true with my consumers is that by the time they reach us, they're in such a state of desperation, their families are in such a state of desperation. Oftentimes we have family members or other people that are willing to help them commit to that process of recovery, and will help them to pay the fees for the process of going through our program. It's kind of a joint effort.
I have a question.
Mm-hmm.
I am an addict. I've been an addict for 14 years. Methadone wasn't for me, but for people that do want to get on it, like you said, there's a problem with your demand, basically.
Yes.
There are major waiting lists. There are people that don't have, 6 months to wait.
Mm-hmm.
So are there things we can do to open more methadone clinics?
I don't know that there are things that, I'm not the one to speak to the issue of being able to open more methadone clinics. What I can tell you in terms of what we provide at Wellspring is that, we recognize the fact, we used to have a waiting list, and it was long, and it was massive. There was a 2 to 3 year wait to get into our program at one point. And what was happening is that, we were calling people back, and, the outcomes were not good based on us trying to track people down to get them into the program. That's one of the reasons that we moved to our open access model. We want people to walk through our door and be able to get help now.
You have to have more money for that too. And if you're an active addict, and you pass an addict money and say, you can go get methadone or go get heroin, most of them aren't going to take $300, and go to the clinic even if they do want the help. And isn't it just as hard to get off methadone as it is heroin?
No, and the reason for that is because if you do it through our medically supervised withdrawal process, you're working with our doctor and you're working with our nurses so that you are not in withdrawal while you're going through that process. We help to wean you down. We help to make sure that you remain stable throughout your whole process of detoxing from methadone.
Well, I have a couple of written questions that have come down. If anybody else
I
has.
have a question too, I'm sorry.
I'm just gonna
I have
ask
a
you
couple
to-
questions, and I'm sure Julie can answer these, so I'll split them up, because there's a bunch. But I know you said that it depends, the length of time a person stays on methadone depends on that person, and I
Yes.
understand that. But what that came up and made me think about then is, are there people who really don't come back off the methadone? Does anybody stay on that for 10, 15 years? I mean,
Absolutely.
what is the time frame? And then that becomes a real financial issue then too. And does methadone itself have addictive properties? I mean,
Methadone is an addictive substance. Yes, it is.
I just wanted,
Uh-huh.
I just wanted to make sure that,
No, that's absolutely fine.
okay.
Methadone in and of itself, yes, it's an addictive substance. We are not putting on any fronts about the fact that methadone is not addictive. It absolutely is. Part of what we do when people enter treatment is they actually sign something called a consent to treat with a narcotic substance. That's part of informed consent. That's part of best care practices in the state of Illinois. Everybody who comes through our door who's put on a methadone knows exactly what they are getting.
Wonderful. And then my last question for you, and I apologize, but are there folks who are just not good candidates for methadone?
Yes.
For medically assisted recovery?
Absolutely.
And that's all part of the process, and then they will still be part of a treatment model, just not that one.
Right,
Is that correct?
yes.
Okay.
That's actually part of the reason that there's a few weeks in between when somebody may enter services through our agency, and if they're going to be a part of our methadone services, there's actually a few weeks in between there, partly because of the availability of our medical director, because we only have one doctor for our entire clinic. But the other part of that is that we really want people to have the opportunity to work closely with our substance abuse specialists, with our clinicians, to help determine if that's really what they need in recovery. That's an ongoing assessment process for those folks that come in those, that time frame of the few weeks that they're waiting to be admitted. If we don't think that it's appropriate for that person, we'll talk to them. And if other referrals need to be made to other programs or to other levels of care, absolutely, we will provide linkage and referrals for that.
Excellent. So then to piggyback off of what the sheriff said a little bit ago, I'm assuming that this is not covered by insurance, is that correct? I mean, and just for that, so that, in the interest of full disclosure, let's.
Funny that you should mention that. So methadone specifically for pain management, if you walk into a pain management clinic and you're being prescribed methadone for pain management, yes, it's absolutely covered by insurance. If you want to be treated for addiction to opiates, no, methadone will not be covered by insurance.
All right.
You-
That,
you-
well, and I think that tells us some of what we need to know and
Yeah.
who we need to be working with as well.
Yeah. Okay, if it's not euphoria that is felt from methadone, then what is it? I'm a recovering heroin addict and I got high on methadone many times. I live by Wellspring and I witnessed a lot of clients nodding out after getting their dose. Does this concern you? Absolutely, it concerns me, and what I can tell you is that because methadone is monitored by our doctor, okay, the doctor puts that individual on a dose of methadone that is appropriate for that person. What that person chooses to abuse on top of their methadone is the problem that you're talking about in that question, okay? Methadone is specific to opiates. The only thing that it treats is opiate dependence. It will not touch any issues that that person may have with benzodiazepines, with cocaine, with any other substance that is abusable.
But methadone can also be abused when you're giving it to an addict and they're still chasing a high.
Mm-hmm.
That's why you end up with people on 180 milligrams methadone, and people are still ODing on methadone and mixing Xanax.
Yes, they are. That's because it's not medically monitored. They're not working with a doctor in a treatment program.
Well, I work with a doctor in a treatment program, but addicts will still lie about things. You're still.
And that's why the individual treatment and the individual counseling and group therapy is so important, because we work to address the issues of why that person participates in those behaviors. Why did they start using in the first place?
Okay. Jessica, I want to thank you very much, everybody. Please give a round of applause to Jessica.
Hi. I'm Julie Brigger. I'm the Associate Director in charge of Clinical Services for our Adult Outpatient Chemical Dependency Program at Chestnut Health Systems. And what I want to start with today is talking just a little bit about drug trends. And what this is a little chart that shows what we've been seeing. We have about 450 open clients at any given point in time. And over the last 5 years, which is what this is tracking, some of the things that we wanted to point out in terms of the importance of talking about heroin addiction in Madison County. Now, one of the things we'll notice is that it started to trend up a little bit in 2009, that through 2009 and part of 2010, what we saw was basically a parallel between heroin use and prescription opiate use. In 2010, though, heroin use left prescription opiate use in the dust as prescription opiates became harder and harder to come by and more expensive. Heroin use became more and more prevalent. And therein lies a big part of the problem that we're all here to address today. As we'll notice, heroin continued to trend upward, unfortunately. And then what happened in the second quarter of 2013 was that for clients in our addiction services programs, heroin surpasses all other substances as the primary drug of addiction. That was, frankly, frightening because of the risk of overdose, because of the risk of other dangerous behaviors that are associated specifically with heroin use. We recognize how dangerous this is, absolutely, for the people here in Madison County. Now, my next slide is, Jessica, will you push the button for me?
It's on your.
Oh, is it?
Working? Yeah,
Oh, this,
yeah.
wonderful. Oh, perfect, all right. The good news is, or one piece of good news at least, is that we're not seeing that so much in our youth services. In our adolescent services, marijuana is still absolutely the most likely substance for our adolescents to abuse. You'll notice all the other substances on there, but eclipsed way more by marijuana use. So then going back to what we're looking at in our adult program, in order to treat this, because I agree that what we've got to be focused on here is solution. We've got to look at what services are available. So what we do at Chestnut is we don't treat disease, we treat people. So basically what that looks like is that we focus on treating the whole person. Not only their substance addiction, but also all of the other problems that are going on. And in order to do that, we offer individual counseling, we offer group counseling, not only to address substance abuse issues, but also to address parenting, to address co-occurring disorders for those of our clients, and there are many, who are struggling with not only addiction, but also co-occurring mental health disorders. We have groups to benefit people who have identified themselves as survivors of traumatic event, because we recognize that particularly with heroin use, the people who are drawn to such are people who are experiencing either physical pain or emotional pain. And we recognize how important it is to address this in a meaningful and appropriate way. As we look at the options for treatment, one of the options that is available through Chestnut Health Systems is medication-assisted treatment, and we do that primarily with Suboxone treatment. What Suboxone is a combination of two medications, buprenorphine, which is a synthetic opiate, and naltrexone, which is an opiate blocker. So basically what the naltrexone does is it kicks all of the opiates out of the opiate receptors in the brain. So if someone who were under the influence of opiates at the time took Suboxone, they would go into a precipitated withdrawal. That's why we don't give Suboxone to people until they're already in some amount of withdrawal. That is the time when it becomes medically safe for them to take it. The buprenorphine part of the Suboxone treatment, it sits in the opiate receptors so that the receptors feel filled. That way, there's no more craving. The naltrexone takes away the payoff from using additional opiates because it won't allow the opiates to connect with the receptors. The buprenorphine sits in the receptors so that it makes sure that the person is no longer feeling cravings, allowing them to be able to focus on something different in their lives, to be able to receive meaningful treatment, to be able to make decisions better, to be able to develop the coping skills that they need. Suboxone is covered by both Medicaid and most insurances. So the treatment program is widely available to a lot of people who have access to health coverage. We also offer other medications through our medication-assisted treatment program. Medications to help with cravings for other substances as well. However, as we're here primarily to focus on heroin, I want to kind of stick to the Suboxone benefits. At Chestnut, what we focus on is recovery. We focus on hope and respect and empowerment. We want our clients to recognize that we know that they're capable of something different than the lifestyle that they came to us from. We want them to know that without a doubt, we're the people who never give up. We're always here, and we will always help. In order to engage in our treatment services, our clients come to us through an assessment process. They call, they get an appointment within 24 to 48 hours of their phone call. Then they begin counseling services through individual counseling, some treatment planning, going into some groups, and then tailoring those groups and those individual services to meet whatever needs they're presenting with at the time. Our clients are encouraged to participate in recovery support. We have recovery support specialists. They are members of our staff who have lived experience with recovery from substance use. And they come in and they talk about their experiences. They talk about their recovery. They talk about how they've achieved it. And they help walk our clients through that process as well. It helps them find the hope that they need. It helps them find the strength. And it gives them the ability to not have to walk into some of those situations alone. We'll walk in with them in order to make sure that they've got the support that they need to embrace something that's more meaningful in their lives. As we look at the importance of health and wellness, we encourage our clients to participate in taking care of and reconnecting to their physical health needs, because so much of the time those health needs go untreated and really not paid attention to so much during the active addiction. So we really encourage them through the process of treatment to not only deal with what's going on with them emotionally, spiritually, socially, but also physically. So we want them to make sure that they're paying attention to all of their needs, that they're meeting their needs in a meaningful way. So as we look, I think, at some of the things that we think are so important, one of the services that we offer is our In It Together family group, and what that's about is that we recognize that, substance abuse does not only impact the person who's struggling with the addiction. It impacts all the people who love them, the people who respect them. And we offer a group specifically for those loved ones. It's open to any member of the community who has someone that they love who is struggling with addiction. And we help those family members or friends or loved ones to embrace healthy communication, healthy problem solving, so that their lives no longer have to be completely taken up by the addiction of their loved one. Because we recognize that the addiction causes a spiral that constricts the lives of everyone it touches. So we encourage not only our clients to get better, but also for their family members to seek out some support. All right. Thank you so much for your attention. Do you have some questions for us? Yeah.
I do, Julie, sorry. First of all, can a person enter, and this might be for either one of you, so I have several questions I've been writing down, sorry. Can a person enter treatment if they're actively using?
Absolutely.
If they are under the influence when they come in, do they need to detox first? And then I have a couple questions about detox, because I think there's a lot of us that probably don't understand what that entails.
They can come into treatment. We do want them to be able to think and remember. So the level of intoxication would matter in terms of recognize, being able to sign consent to treat, being able to sign consent for authorizations for us to release information to other people. So we want people to be able to think as they're making those decisions. But yes, people can come in to treatment. In fact, more often than not, truly, our clients are seeking our services while they're still struggling. It's not usually once they've, stopped the struggle. It's generally during the struggle.
And then are most of your clients outpatient? I know you have, I work for Chestnut as well, so I know just a little bit, but outpatient, I know you have intensive outpatient and then residential. Can you talk maybe a little bit about
The different services?
About the different services?
Absolutely. We have outpatient programming, which is group and individual sessions that happen for clients who are attending fewer than 8 hours per week. Our intensive outpatient services are for clients who are attending with us from anywhere 9 hours to 15 hours a week. Then there's residential treatment services that we don't have in this area, but we do have through Chestnut up in Bloomington. So, and we determine who gets placed in which level of care depending on the needs they present to us with and their willingness to participate.
And then how much does detox cost? If they need to come into and they're trying to, is there a process? Is detox readily available? And is there a process in your estimation?
Detox is available for people who have health coverage. For people who don't have health coverage, last time I checked, $2,500 to $3,000 for that 3 days. The good news is with the expansion of Medicaid that happened as of January 1, a lot more people are eligible for medical card through the state of Illinois, which is great. So in terms of being able to access some of those services, that did open some things up.
How do they get connected with those medical services or the insurance?
The county health department has people who are there who sign people up every day, right?
Well, the program stopped March 31st for the actual insurance exchange, but the Medicaid portion of it absolutely exists still, and we can assist.
How do people get connected with your family group? How do they sign up?
All they would need to do is call our office, which is our main Chestnut number, which is 618-877-4420.
Can you repeat that again?
Absolutely, sorry. 618-877-4420. Ask for our chemical dependency services, and then our intake coordinator takes those names down, and we get people signed up for that group.
Where are the breakdowns and what is the disconnect between people wanting treatment and not being able to get treatment? Does that exist? Where are you guys seeing that? What are things that you think maybe the court system or the medical system could do better to help people who want to get treatment make sure to be able to get the treatment they need?
I think that in terms of helping people get the treatment they need, I think the idea is that help is available. I think that there are a lot of people, while we are a pretty large provider, we've got 450 open clients, that's kind of a lot of people, but I think that there are still people who aren't sure where to go in order to be able to access us. I think it's about recognizing where the help is available and then just making the phone call to come on in.
Two written questions from
Sure. All right, if Suboxone is supposed to be highly regulated, why is there such a street market for it? Suboxone is pretty highly regulated. Each doctor who prescribes it prescribes only to a certain number of patients at a time. Also, they have to have a specific DEA license in order to be able to do it, so they have specific certifications that go with that as well. Now, why there's such a high street market for it, gosh, I think that part of it is probably because it does include the buprenorphine, but the other part of it is I think that there are people who are looking for some ways out of active heroin addiction, and I think that they're looking for ways to be able to do something that is less risky than is the use of heroin. I think that that's part of it. I think that part of it is also that treatment is a process that requires a lot of lifestyle change. And coming into treatment and committing to that process is a big commitment, and it's really scary for people who've never done that stuff before. Asking them to make that entire lifestyle change is a big deal, and I think that wanting to do it little tiny bits at a time, you know, well, maybe I'll just use this medication for a while and then I'll get better, and maybe then I wouldn't have to do all of that other stuff. That may be part of it as well. You know, I think that we really want to look at making sure, though, that as we look at treatment and making sure that it's meaningful, that the whole person is being addressed, and not just the medication part. How long is the process to wean someone off methadone?
Depends on the person.
Right.
Like I said, that goes back to working with our medical director, and it also goes back to the fact that people that coming in on methadone, even if they're in the process of detox, they're still seeing our nurses every single time they come to that window. So the entire process is still being medically supervised. And you know, just like you can't pick one dose of medication of anything that would be appropriate for every person, the same thing applies with methadone. It's just a medication. It's going to be different for every person.
And then the next question is, how long does the individual take Suboxone? That averages anywhere from 3 to 12 months, depending on the person. As soon as someone wants to begin to taper off of Suboxone, then our doctors do that. They taper, will begin a taper immediately. Why is this covered in methadone not? Oh, I don't know.
Good question.
I don't know the answer.
I have another question.
Yeah.
I was sitting here, Julie, while you were talking about the devastating effect on families, and I couldn't help but think that we probably in our audience today have folks who have been just seriously impacted by this, either on a personal level or a family member. And I just wondered what the two of you would say to those people, just about how, you know, steps that they could take, or how there is some hope out there. What would you say to the folks, I guess, in the audience about dealing with a family member?
Right, absolutely. You know, as we look at this, there is hope for recovery, that people get better every single day, that we see people getting better every single day. And that's what brings us back to work every single day.
Let us be a partner in helping you to help your loved one.
Definitely.
Because it's, I mean, we understand that addiction is a family disease.
Mhm.
It's not just the person who's using that's affected by that. Every person that, you know, the person that's using encounters is affected by that person's use.
Absolutely. And I think also, you know, there are a lot of support groups that exist. There are wonderful programs, Al-Anon, Nar-Anon, to help offer support to family members who love someone who's struggling with addiction. There are support groups for people who have experienced traumatic loss, like through overdose or something like that. There are loss support groups as well that exist in the community. Yeah.
I just have a question about, Jessica had mentioned, and I agree that the vast majority of the heroin users started out on the pills,
Mhm.
the pain pills. You know how it just happened. I mean, go to the doctor for this or that.
Sure.
And it just happens, and that's how it leads into heroin. But then you're also both talking about getting, in the counseling, getting to the real problem of why they're using drugs. So that kind of, my daughters started out with the pills, and I just wonder, you know,
Well,
if
part
it's
of the
underlying, if it's just about, you know, accidentally getting addicted, or is there real reason underlying?
Well, and keeping in mind too that a lot of times that kind of accidental getting addicted part that you were mentioning has to do with physical pain. And if that physical pain is ongoing, then we've got to really look at how to address that and work with physicians in a meaningful way as partners to be able to figure out what's going to work for that client. Because if they're experiencing that ongoing, physical chronic pain, that's something that has to be addressed as well in terms of, right, exactly, in terms of what are the other ways that may not be pharmacologically based to deal with pain in order to deal with some of those things and decreased mobility issues. And I mean, there are a lot of those physical health things that absolutely do go along with this. Because again, people who find themselves addicted to opiates oftentimes have that ongoing issue with pain, whether that pain is physical or whether that pain is emotional. All right? Thank you so much. Oh, yeah.
I do have a question, kind of piggybacking off of that. If we know that a lot of early addiction starts with the prescription pills and working with physicians, have you seen any kind of change as far as prescribing those for chronic pain? Is there any active change going on as far as other means of treating that pain instead of prescribing those?
I think a lot of physicians are open to that. I mean, given the fact that I'm not a physician, I can't actively speak to exactly what's in their brains. But I do think that there are a lot of physicians at this point who are open to doing something that's a little bit different, and trying new things and including, various kind of therapies that, to address the physical health problems.
We're hoping to get somebody from the medical community to come in and talk and address, and that'll probably be one of those tough questions that needs to get asked, because it does seem to be part of the regular regimen of medical care nowadays. I mean, go home and look in your medicine cabinet and look and see whether you have some kind of a painkiller sitting in there, uncontrolled, unlocked.
Sure.
I know I did. In spring of 2011, when I started getting involved in this, I was no different. My parents, my friends, my neighbors, we all did. And the way to deal with that is, we're involved in a program called Lock Your Meds. And one of the things that you can do is, if you have medications in your home, you need to keep them, or somebody that you're helping take care of, please lock them up. All you need is a simple lockbox, because a person who's starting down that road isn't going to break it open. And if they do, call 911. You can get somebody involved, and you have a problem you need to deal with. But if you don't need those medications, what you can do is drop them off. Many of your local police departments, our sheriff's department, have boxes open 24 hours a day. You can walk into the lobby, you can drop them in there. It's like a mailbox or a book deposit. Those things are delivered immediately and directly to an incinerator. It's all burned. Nobody looks at it or has anything to do with it. It's just burned. The sheriff's department has one, many of the local police departments, and coming up on the 26th of April? April 26th, starting at 10 to 2, here at the Madison County Administration Building in the parking lot to the north. We'll have a drop-off site, and there are going to be other drop-off sites around the county as well. Look out for those. If you have medication, or people who do, get rid of it. You can become part of the solution to that. But I agree, that's a really interesting question. I think that's something we need to hear from the medical community about how they're addressing that issue, because that does seem to be a root to the problem.
Right.
So thank you so very much. Thank you to our two speakers, Julie, Jessica. Thank you for coming today, giving your time and the information. We're going to keep doing this. We think there are a lot of different parts of this story that still need to be told. Obviously, we talked about the medical community, their involvement. I think that we're going to be hearing from some recovering addicts, from families, maybe other treatment providers, maybe other people involved in delivery systems. We want to, our health department is very much involved in this, so we want to make sure to try and bring in all the different pieces to this puzzle so that we've gathered as much information as possible, so we can then take that information and distill it into some solutions, some concrete stuff we can do to help. Part of that is what we did today, is connecting people with resources that are already there. If you're in need, if you're a family member in need, or somebody, you've just heard from 2 possible treatment resources, so you have that available. But we're going to be looking for more. If you are interested in presenting to the group and you're not afraid of public speaking, please send us an email. Tell us who you are. Tell us what you feel that you have to add to this discussion. And we've gotten several of them, and some of the people who've written into us, we're going to be dragging them in here and giving them the opportunity to do just that. But we want to hear from you as well. And that's not just family members, not just recovering addicts, but other people who are involved in this in any way or if it's touched your life. We want to hear from you. So once again, I want to thank our two speakers. I want to thank everybody for coming today. Please keep coming. Be part of this discussion. We really are trying to help our community. That's what this is all about. And the only way we do that is get as many people engaged as possible. So we'll be sending out a notice on another meeting probably in the next 2 to 3 weeks, but depending on everybody's schedule, it may take another week. But we'll do it as quickly as we can so we can keep moving forward. And once again, if you have anything to add, please don't hesitate to send an email. We want to get you included. So again, just going to close it for today. Thank you so very much, everybody.